If you live in Oregon, you're probably well aware of some of the healthcare challenges we all face. For example, Oregon is either the worst or close to the worst in several categories when it comes to healthcare. In addition, the healthcare system has been plagued with labor shortages, and many hospitals are struggling to negotiate wages with nurses who are also facing severe burnout. But as bleak as the situation might seem, there is still hope for a better future, even if it is going to take quite a bit of work. The healthcare industry is full of amazing people doing great things, even if that work can sometimes be overshadowed by some of the larger issues. So while we will touch on some of those larger issues today, we're going to be zooming in a bit to learn about some of the positive things happening in our own backyard. We're going to be taking a look at Providence in Newberg. Now, if you live in Newberg, you're almost certainly familiar with the Providence Hospital across from Crestview Crossing. But you might not be familiar with the Providence Newberg Health Foundation and how they work to support the Providence Medical Center and the greater community. So today I'm talking to Dr. Amy Schmitt, who is the Chief Medical Officer and Interim CEO at Providence Newberg. I will also be talking to Doug Cain, who is the Executive Director with the Providence Newberg Health Foundation. So we will be discussing the different roles between the medical center and the foundation. We'll be discussing the origins of Providence and its mission, as well as some of the current challenges in the Providence system and healthcare as a whole. We'll also get into some of the possible implications artificial intelligence could have on the healthcare industry, and we'll finish up with ways that you as a community member can get involved. Hi, I'm Daniel Roberts, host of the Giving Town podcast, where we share stories of hope and generosity in Newberg and the surrounding areas. We live in an amazing community full of incredible people who are all working to make Newberg an even better place to live. And this podcast is all about sharing those stories and helping the people in our town be inspired, get involved, and have hope for our future. This podcast is brought to you by my real estate team, the Joyful Roberts Group, and is part of our mission to serve this community, not only by providing amazing service to our clients, but to also help Newberg be an even better place to live. So if you're looking to buy or sell a home anywhere around Newberg, reach out to us. We would be happy to serve you. Well, thanks for tuning in to this episode of the Giving Town podcast, and I hope you enjoy this conversation with Doug Cain and Dr. Amy Schmitt. Well, Doug and Amy, thank you so much for joining me today on the Giving Town podcast. I'm looking forward to learning more about Providence, both on the hospital side and the foundation side. So it's great to have you both here.
Yeah, thank you for having us.
Yes. Happy to be here.
So can you explain, so Amy, you're representing the hospital side as the CEO there, and Doug, you're representing the foundation side. And I think a lot of people aren't even aware that there is a difference, or that there is a foundation that's separate from the hospital. So for people who aren't familiar with the foundation and how that dynamic works, can you share a little bit about that role, like what the difference is there?
Yeah, well, the foundation comes alongside the hospital. I always say that in healthcare, it's very complex and it's very expensive, and there's always funding gaps. And it's the role of the foundation to partner with the hospital to identify what those funding gaps are, so we can provide the best care and treatment for our patients. And statewide, we have 8 foundations in Oregon, Providence Foundations of Oregon. And so we're also our own separate 501c3. And so we are separate from the hospital, even from a legal side. And so like I said, we come alongside and we support the hospital with any of the funding gaps that are there.
So what kind of funding gaps would those be? Because I think a lot of people would be surprised with the cost of medical care and insurance. Like, What do you mean there's funding gaps? I thought hospitals made a ton of money. So what kind of funding gaps might there be?
Yeah, a lot of it is equipment is a good example of that. Capital equipment, we need to make sure that we have the best equipment for our patients, or just service for our patients, support for our caregivers as well. There's a lot of different ways that we can come alongside. But I would say probably the most common is making sure that we have the right capital equipment and the right facilities and that sort of thing. And so that's kind of the role of the foundation, to provide that additional support for the hospital.
Okay. What's an example of equipment you might need to buy through the foundation?
Oh, let's say an ultrasound machine or a 3D mammography, which is a big one. I mean, that's something that we were able to add several years ago. And so those are some examples of what would be needed.
Tell me, what does something like that cost? I have no grid for what?
Oh, 6 figures. A 3D mammography machine is quite expensive. But I would say, and Dr. Schmitt, you might, it could range. It could be anything could be anywhere from $10,000 to $100,000. It all depends. So.
And I apologize, Dr. Schmitt, I call you Amy because that's what's on the email.
Yeah, no, feel free. Please call me Amy.
Okay.
Yeah.
All right, we'll do, and we'll just disagree, Doug.
Okay.
I'll keep calling her Dr. Schmitt.
Okay.
All right, so Amy, from the hospital side, how do you see the role of the foundation? Like, how does that support you in your work?
As Doug alluded to, it does help with funding gaps. So we have annual allotments of funding for capital projects. So, as our x-ray machines become outdated or break, we have a certain amount that we can spend to replace that type of equipment, but it never fully meets the need. And so it ends up that we prioritize those that are the most critical needs, and then those that are deemed slightly less critical just don't get funded. And yet those are things that make our caregivers' lives more efficient. They help ease the way of our patients. They make the patient care just better in a lot of ways. And so they're able to come alongside us when we can't use the funding that we have from the Providence system to purchase those items or to do outreach in the committee that doesn't have a return on investment in financial means. So those are fun projects to be able to partner in.
Okay. So as a doctor, as an MD, you actually did practice, is that correct?
Yes.
Okay.
Yeah.
So how did you end up in the role as CEO?
So I'm technically an interim chief executive. I came to Newberg in 2007 as a hospitalist physician. I'm trained in general internal medicine and practiced as a hospitalist all the way up through last summer. About 11 years ago, I took on the role as chief medical officer and have done both for that 11 years. Really stepping into a need. I did not go into medicine thinking I would step into administration, but when you see things that need to be done and nobody else is stepping forward willing to take that on, I feel like it's a need I can meet. So the interim chief executive role really just fell into my lap when our prior chief executive stepped away, and we had just gone through a lot of trimming of our leadership structure, trying to make healthcare affordable, eliminating any redundancies in leadership, and then all of your backup leaders are suddenly not there. So I was asked to take this on and did it as an interim, and then starting the end of this month, I actually go back to some of my clinical practice part-time.
Okay. Doug, how about you? How did you end up in the foundation role? Is this what you thought you were going to do when you graduated high school?
Not really, no. But I will say I've been with Providence almost 10 years, and here in Newberg almost 5. And before I came to Newberg, I was a gift officer for the Providence Cancer Institute, where I split my time between Providence Portland and Providence St. Vincent. It was a very meaningful position of mine. I've always had an affinity towards cancer. I think that's such a great cause, and I know Providence does such great work. I did get an opportunity to take the role as the executive director of the foundation here at Newberg, and I love that opportunity. I've really loved this community. I've had an opportunity to get involved. I've joined the Rotary Club. I'm part of the Newberg City Club, and just have really just fallen in love with the people at the hospital. It's just been a great place for me to reside. Yeah.
So the origins of Providence go quite a ways back, and I think that'd be a fun story to share as well, how the hospital got started, how the foundations got started, that model. Could you share a bit about that?
Yeah, so Providence actually came to Oregon in 1852 as part of a missionary journey by the Sisters of Providence. They came to meet the needs of elderly, orphans, and others who weren't getting primarily social and educational needs met. They opened a school and orphanage in the 1800s and finally opened the first hospital in the Pacific Northwest in 1858, which is the current day Southwest Washington Medical Center. It's interesting as you look through the history of Providence, they opened many of our current day hospitals in the Pacific Northwest, and then at times along the way, due to limited resources, inability to update the infrastructure and equipment, would hand some of those hospitals off to the community, like the Astoria Hospital, now known as Columbia Memorial Hospital. That one was also founded by the sisters. So it's been fun to watch that journey and see it unfold. They came to Oregon with the first permanent hospital in 1875, which was St. Vincent's Hospital in Portland. And then Providence St. Vincent's assumed management of the Newberg Hospital in 1979.
Okay.
And then, as you know, we built the new hospital in 2006, and Providence also helped care for the very first COVID patient, January 20th, 2020. We admitted our first U.S. case of COVID-19 to the Regional Medical Center in Everett, Washington. So definitely been a community partner for pushing 200 years.
So what's the story of Providence coming to Newberg in 2006?
So they had already assumed management of the old hospital, and that was a partnership that had been in place since 1979.
And what was that? So 1979. What was the hospital kind of up to that point? What's the history there?
I think it was an independent. I don't know. That's a good question.
It was the Newberg Community Hospital, and then Providence officially changed it. Well, it officially changed its name in 1994. And became the Providence Newberg Medical Center.
Okay.
Yeah.
And now the building that's over there across from Crestview Crossing, is that the one built in 2006?
Yes, the main hospital building was built in 2006. And then the plaza, which is the newer medical office building across the street, which I guess is technically directly across from Crestview Crossing, that completed building.
We had our ceremony in February of 2020, right before the pandemic hit.
Oh, fun.
Yes.
So not the way you plan on having that start.
No.
Okay. So then how about the foundation side? When did that?
Yeah, it's a great story. So back in the mid-'80s, it was around 1986, a group of physicians got together and said, we need funds. And it was led by Dr. Stanley Kern, who also was a longtime board member. He kind of led that effort. And as well as Bob Herford, he was another one of the original members of the foundation. Of course, his wife Dee Dee is a current member of the foundation, and so they got together in the 80s and started raising funds. And back then, it was called the Newberg Community Health Foundation. And of course, then when Providence took over, they changed it to the Providence Newberg Health Foundation. In 2001, they began a feasibility study to plan on we need a new hospital. And it was led by the executive director of the foundation at the time was Sherry Scales. It was also, they had a couple of committee chairs, Kurt Walker and Jim Hurt. The honorary chair was Joanne Austin. She was the honorary chair of that committee. And they started the campaign in 2002, didn't go public with it until 2003. But it was in 2003, September that year, they made the Guinness Book of World Records for the most shovels used at a groundbreaking ceremony. It was like 2,473 shovels, if my math is correct. And apparently they had everybody in town say, grab a shovel and, we're all going to do this. And so it made the Guinness Book of World Records. And that was in 2003. 2006, it was June 16, 2006, when they started to transport the patients over from the old hospital to the new hospital. So it was 18 years ago. It'll be 18 years this next June. The foundation raised $5.3 million for the campaign, and that was the funds that came from the local community, which was a good chunk of money back then.
Yeah, and that's a good chunk of money now.
Yeah.
It wouldn't maybe go as far as building a building, but still a lot of... So that was another question I was curious about is how is the foundation primarily funded?
It's funded through individual donors, and we get funding from individuals. We get them from corporate. We get them from family foundations. We do get some grant funding as well, and so it just overall. And as a matter of fact, I just looked this up. Since the very beginning, we've raised almost $18 million. We're like $25,000 to go to get to 18, and so we'll make that this year, obviously. And over 42,000 individual donors have made donations to the Providence Newberg Health Foundation over that time frame. Long time.
That's incredible.
Yeah.
So with the origins and how Providence began, it's interesting reading the mission statement. So it says, as expressions of God's healing love witnessed through the ministry of Jesus, we are steadfast in serving all, especially those who are poor and vulnerable, which is quite the mission statement. So what is your interpretation of that? I'd be curious to hear both of your inputs and what that looks like in practice.
Yeah, it's something we really try to keep at the forefront today. We see healthcare as a ministry, We are not just ministering to somebody's physical needs, but they always come with emotional, psychological, social health needs as well. And so trying to recognize and meet those needs, and especially for those who are having trouble advocating for themselves or reaching those services for themselves. The goal is to improve access, eliminate barriers, and if someone needs an additional step to allow them to do that, then that's what we're here to do, is not just have open doors, but to go out and meet the need in our community.
Yeah. It's know me, care for me, ease my way. That's always been part of the philosophy behind the Providence mission. Yeah. And what I love about Providence, and we can't always control what happens to a patient, but we can control how we treat a patient. And Providence has always taken patient care very seriously. And I think that's the thing, and I know Amy would probably agree with me. It's the thing that gets us out of bed every morning, is that idea that we work for an organization that truly does care for the poor and vulnerable, and we have a purpose and a mission to live out our job every day.
Yeah. And I think as we think about the definition of poor and vulnerable, any one of us can be poor or vulnerable on any given day. When you're laying in a hospital bed not feeling well, you feel pretty vulnerable no matter what you may have been like the week prior. So we recognize that and try to ease that experience.
Well, I think poor, that's an interesting way of phrasing that, because often we think of poor as financial, but when you look at, there's the emotional, the social health, there's obviously physical health, and some people who the last person you might think of as poor, maybe a billionaire, is, has no real social life. They don't have people who actually, they would feel love them. They are, you can have poor physical health. So it's an interesting way of kind of being able to look past some of those things. It's interesting and really intriguing to me when you research and look into the story of who Jesus was as a person walking on the earth. He didn't have a medical degree. As far as the Bible is concerned, and I believe too, that he was the Son of God walking, ministering healing to people through laying hands on them or speaking healing, and so it's just really interesting to me that it's as expressions of God's healing love witnessed through the ministry of Jesus. Like, how do we walk in that? It's just one of those things that kind of makes you think, like, okay, Jesus told us to do the same things. What does that look like now? That's kind of the question. We try to live that out.
Yeah. And it's hard to isolate one component of care. We have people who are suffering who really can't make headway in their physical health until they deal with their spiritual unhealth or their emotional or mental health needs. And so making sure that we maintain that perspective of the whole body care, whole person care. There's times when our chaplain is the most influential member of our care team, and they're able to reach that person, help them to open up, help them to be willing to receive care, because that's often the barrier is that connection and willingness.
This is something I hadn't really planned on asking, but it's a really, I think, relevant point. The more that we study, at least from my perspective, the more that we do research on how the body works, how the brain, body, mind, soul connection, whatever that is, like you can find studies that anxiety causes physical health problems, stress, bitterness, deep-seated anger, fear, all of these things that we wouldn't really consider maybe as a part of healthcare are actually very instrumental. Even brain research into why do happy people get sick less than anxious people? That's interesting. So I'm curious, you're much closer to this than I am. How do you incorporate that into daily practice? How do doctors use this and say, okay, well, we have a patient in here, they're showing us this need, these symptoms, yet it seems maybe like there's underlying, maybe they've just gone through some recent trauma. Mm-hmm. And then maybe that trauma is what's causing this, that this pill we're prescribing may cover up some things, but doesn't solve the issue. How do you manage that as a doctor?
Absolutely. Well, the first piece is identifying it. As you alluded to, sometimes the manifestation is very physical. It's nausea, or I can't eat, or I I have no strength. I can't get up and do my normal activities of daily living. And so looking for the clues that maybe there has been a recent trauma or there's other things, watching the dynamics with family members can give you a clue. Listening to the nurse who's at the bedside much more often and can see some of that dynamic and how it plays out, that, oh, well, they'll eat when their family isn't here, but then when the family's here, maybe they can't eat. So sometimes you have clues along the way. Sometimes you end up doing the full medical workup and kind of coming up dry, and then you're left investigating, well, maybe we need to look at other possibilities. Maybe we need to have that behaviorist from our PMG clinic or from George Fox come and talk with this person and find out, are there other things that are playing into this symptom that's preventing them from entering the healing process. And so we partner with other specialists once we kind of exhaust our ability to come to an answer. Yeah. And sometimes our chaplains are part of that work. When they're doing their rounding, they can pick up on things that maybe we've missed. So it's definitely a team effort.
Yeah.
Yeah. And, it's interesting because at the foundation, we've always been trained that gratitude is actually healing for a patient. And when a patient has an opportunity to express their gratitude, it does help in the healing. And it doesn't have to be monetary. It could be just expressing themselves. It could be telling the nurse, thank you for, keeping me warm. And it's always important that we reciprocate what they say back. Well, hey, thank you for sharing that with me. It's you never want to discount someone's gratitude. I think that's really important that you make it clear that you hear it and you give it back to them. I think that's really important.
Along those lines, there's times when just the conversation is healing. So, just someone sitting down with them and giving them a chance to share the trauma, then suddenly you start seeing improvement in the physical symptoms. And I think sometimes we keep so much bundled up that it clearly manifests in physical ways. So creating that avenue for healing is really important.
It really makes me wonder, hundreds of years ago when we used to put leeches on people and say, probably must be that you took too much blood. Yeah. We now look at that as being so archaic. It makes me wonder in the future as we continue to learn more about, the much deeper layered side of people. What are we going to find and look back on and say, I can't believe that we would treat people that way, or that we were so blind to those things. Yeah. But obviously hindsight is 20/20.
Right.
So one of the other things, when I was looking around on the website, it talked about the different community benefits that you guys do. Can you share about those?
Yeah. So every year we want to make sure we're giving back to our community. We have a community benefits program that has oversight by our Service Area Advisory Council, and that council is made up of community members. We have currently, the chair is Mary Peterson at the George Fox. She has been involved with Providence for many years and serving as our current chair. And other members from that committee who we try to select based on, diversity of business, ethnicity, social groups within our community. And then we look at our community health needs assessment. So that's basically a document that is the compilation of many surveys, questions, and work done by our Yamhill County Public Health, by our community care organization, to come up with a list of things that are high priority items for the health of Newberg and for our service area, which does span outside of Newberg. But the top hitters for our last community health needs assessment were mental health, access to care, food security, housing security, those things that we know if people aren't eating and don't have a warm place to sleep, then meeting their physical needs is extraordinarily difficult. And so a lot of our benefit for this past year has focused around how can we make sure that we're meeting those needs. So our partners specifically for this year have been Lutheran Community Services. They provide many services to our community, one of which is the Family Relief Nursery. They also provide mental health services and some school-based health services. The Yamhill community programs through YCAP. They do some housing work, mental health, substance use clinics. and the Community Wellness Collective, currently running a local shelter, provide mental health care in that shelter as well as elsewhere. And then the Northwest Christian Church, they've been a big partner for us throughout the pandemic, providing both transportation and food pantry services. So they've really been meeting the needs of our community in those areas, and we want to make sure they're supported in that. So those have been our big partners for this year, 2024.
It's amazing how many, obviously enough to do a whole podcast on, how many great organizations there are. That it's amazing to me how many times I'm learning about a new one. Like, I had no idea that was around. And if I didn't know that guy who talks about this all the time, then how many other people haven't heard? So I appreciate you sharing about that. One of the other things that I don't think I had on here specifically, but I know you guys are really involved with the Peace Trail Village, right? So where are things at with that? What is your involvement as a hospital and/or foundation?
Yeah, so I guess I wouldn't say that we're closely involved in that.
Oh, okay.
When it first was proposed, we had agreed to partner on some of the social service needs, the mental health needs that often comes with that sort of a project. As things have gone on and timelines have been spanned out, we've been less involved because that's really the niche of service that we were planning to provide for that. So outside of that, we weren't part of the actual housing endeavor. It was really just if the Peace Village was put into place, that we would be willing to come in and provide some of that support that's needed.
Gotcha. Okay.
We are working on a partnership with Catholic Charities to build permanent supportive housing and affordable housing in Newberg, and that would be adjacent to the hospital.
Okay.
That's been several years in the making, and probably several years before we see it come to fruition, but that would be right adjacent to our hospital campus and provide some needed housing for those groups.
Okay. What would that look like?
It would probably look like a apartment building or a hotel. It would be right there on the corner of Highway 99 and Providence Drive. There used to be an old house that was torn down, and we've donated the land to Catholic Charities, and then they're the ones who would own the project. So really, we've donated the land. We would again help support the social needs, the behavioral health, some of the services that they would want in there. We've also talked about adding a community teaching kitchen and a commercial type kitchen that some of our community partners could use.
Absolutely. And the supportive housing unit at this time, there is no financial obligation from the foundation at this time, but there could be some respite rooms, things like that we can fund once the program is up and running, and when that happens. So.
Well, being in real estate full time, I'm very close to the need for affordable housing. It is, I don't know what word, not funny, it's kind of like intriguing in a sense of like, oh man, like kind of in an alarming way that there's a lot of people who make really good, good living wage jobs, or should be living wage jobs, that can't afford to buy a house. You got maybe one partner that's working, and the others are at home with the children. And unless you're making a 6-figure salary, you can't afford to buy a home. And so affordable housing now looks like homes that are crammed together, which everyone also complains about, which I get a lot of those complaints as if somehow it's my fault because I try to sell that. What the housing need obviously is very clear. And you're a hospital; it's not your job you're not a developer. So it's cool that you're even thinking about it and wanting to provide solutions. But what could that look like? Who would be the people that would move into that kind of housing?
So they're looking at 3 groups to be able to support with this kind of a housing endeavor. And again, this would be Catholic Charities work, but we are, part of the conversation and trying to have some input. So I believe they have talked about maybe 8 respite beds, which Doug spoke to, and those are rooms that allow people a place to go when they're released from the hospital who aren't quite ready to return to their prior environment. So if someone's homeless, they're in the hospital and they're being discharged with oxygen or a medical device that needs to be plugged in, or they need home health services. You can't service that when someone doesn't have a home to reside in. So it would be kind of a temporary housing until they're fully recovered from their medical condition and able to go to whatever living situation they were participating in before. The affordable housing and the permanent supportive housing have varying levels of government funding. I believe the affordable housing is 70% government funded and permanent supportive is 30% government funded. I'm not the expert, so don't quote me on that, but that's what I recall.
One of these days I'll get the Housing Authority of Yale County in here. They could share more on that side of things.
Yeah, so, I'm sure that's going to come with some criteria that the government is going to have for them to qualify.
Okay. Yeah. One of the other questions I'm sure that you've often heard a lot about or comments you've heard a lot about is just, as I mentioned earlier, how medical costs and insurance costs are so high and seem to be, doesn't seem, from my perspective, to be a clear end in sight to that. So what are your perspectives on just medical costs in general, and what is your perspective on that?
Yeah, well, I wish I could say it's going to get better, but the forces driving it are not changing in the near future. So labor is our biggest expense. People, investing in people, caregivers, that's our biggest expense as a healthcare industry. And then supplies and pharmaceuticals are not far behind them. All of those things have seen about a 20% increase in cost over the past few years. There is certainly a desire to provide affordable health care, but when we look back in 2011, the average deductible was $650 annually. Now it's well over $1,500. And there's only so much the system can absorb. That cost of labors, pharmaceuticals, and supplies inevitably does get passed on to the patient and the consumer, because there's only so much we can do as a healthcare system. Reimbursements have not kept up with that. So over the past 2 years, as inflation has outpaced reimbursements, Providence has seen huge financial losses. And so really over the next year or two, our goal is to try to get back to a break-even point. The Providence health system lost $1.7 billion in 2022 and $1.2 billion in 2023 on their patient care services.
So basically a patient comes in, say they stay for a couple of nights, there's the cost to that, and then the reimbursement does not cover the cost, essentially, is what?
Correct.
I heard the number was that for every dollar we bring in, it costs us $1.40.
Wow.
And you can't sustain that.
Right. So how does that change?
So we're going back to our payers to renegotiate. You probably heard in the news earlier in the year when we almost didn't renew a new contract with Blue Cross. That was overpayments, trying to pass on some of our costs to our insurers. Interestingly, during the pandemic, our insurers were the only ones really making money. Patients were suffering, healthcare systems were suffering, but that intermediary payer did make a profit. And so trying to pass some of that cost on to our insurance companies to account for that increase in cost. That's really our biggest avenue. We've already trimmed a lot of our costs as much as we can. I spoke to trimming of our leadership structures, trying to consolidate how many leaders we have, but the work remains. You still have to shepherd people, and that is a hard job when you have few to do it. We're looking at other opportunities to invest in other ventures to help support the patient care experience. So, we're finding that patient care is no longer a self-funding business endeavor. You've got to have other programs to help fund it. So Providence has its hand in some other, we have a venture in India that's looking at IT security, healthcare, cybersecurity, and those are services that when we're successful, we like to be able to sell to others and help fund our healthcare venture with those kind of things.
It's interesting talking about the costs and the expenses, and it's a good example of how there's always two sides to the story. Because recently, I know in the news was the nurses who were protesting and on strike. I don't know all the details of that, but it's interesting because one perspective can be, look at this greedy hospital who's not wanting to pay their workers. And on the other side of that is, okay, there's a hospital that's trying not to go under and trying to figure out how to do that. So what's your side like from the hospital's perspective and maybe from the nurse's perspective too. I don't really know the full story.
Yeah. No, I mean, we need a new nursing contract. We have not had a new nursing contract in over 3 years. So they had a 3-year contract in place that expired the end of December, and we would love to get a new contract in place with competitive wages so we can recruit, because right now we're having a really difficult time recruiting. So everyone has the same ultimate goal in mind. We want a new contract. We want to pay market competitive wages so we can recruit and not rely on agency or kind of third-party nurses to try to fill gaps in our staffing, which is way more expensive than hiring long-term nurses. But where that dollar amount actually falls out is always hard to come to an agreement on, what that whole package of a contract looks like. And the details are really where we're kind of in a stalled situation. So that negotiation process continues. We're trying to make sure that we remain financially viable and yet pay our caregivers enough that we can recruit and retain and keep our doors open.
Not an easy situation, I'm sure. So another thing you mentioned was the cost of labor, kind of on that note, but separately is really high, which is, I'm sure, in part because there's a shortage of workers, right? So like the less workers there are, the more you have to pay to get them. And it's interesting to me that Oregon is actually one of the worst states in the country for and I don't know how it is on healthcare in general, but for mental health, depending on where you look, it's either the worst state or like the third worst state for that, which is interesting because there seems to be a big emphasis on it, yet we're the worst state in the country, or at least close to it. So why do you think that is, and how can we change that?
Yeah, that's a good question. Oregon, unfortunately, is worst in the country for a couple of things, and number of hospital beds is definitely one of those as well. But mental health has been an area of focus. I think it is improving in recent years as it's recognized as a deficit. There's funding being infused into those programs. Insurance is being pressured legislatively to provide mental health services and improve access from a financial standpoint. But it's hard to deliver care that's really accessible from a social standpoint as well. So, a lot of the people who need it don't come to our doors and ask for it, or they don't call in to make an appointment. So you have to try to capture them when they're in your network for another reason. So our ED visits are a place where we see a lot of people with mental health conditions that might be untreated. We've developed a building BOB program, building outcomes through bridges.
Better outcomes through bridges.
Better outcomes through bridges. Yes. Thank you, Doug. Yep. To try to identify those people who aren't getting mental health services who need them, and then connect them with those services following their ED visit. So you have to get creative about how you deliver mental health care, because it's not the traditional physical health patient who's calling into the doctor's office asking for the next available appointment. They're often at home, reclusive, isolating, and so finding avenues for that is important.
And that's another good example of how the foundation can come alongside and support it, because the Better Outcomes Through Bridges program, or we call it the BOB program, is a foundation funded program where we can come alongside and help our caregivers to provide that assistance that the patient needs. And so it's just another example of that. Yeah.
It's just another interesting point. Do you have any knowledge or statistics of the instances of mental health and how that's changed over the years?
I don't have statistics offhand. We do know that suicide rates have increased dramatically. Now, those correlate with mental health conditions. They're not they're not a direct correlation, because we know there's a lot of other things like isolation and financial stressors and social stressors that can drive suicide rates. Also, just the lethality of our drugs now. Overdoses are one of our leading causes of the death, which unfortunately is not always intended. There are many times, not that it's Not that it's positive when it's intended, but sometimes it's recreational drugs that are just so lethal that it's an accidental overdose.
Like fentanyl.
Fentanyl is exceedingly lethal, and having additives that make it even more lethal. And so we're seeing more and more opioid-related deaths, and that's been hard for our community.
Yeah. Well, and one thing I was thinking about is some of the more underlying social aspects of health. We are a much more individualized society. I've had a few different conversations with people talking about, in many African countries, there's the concept of Ubuntu, which is I am because you are, or I am because we are. And the philosophy is that we're really meant to do life with each other. We're really meant to do life in a community. And in many neighborhoods, you're in your house and you have all your own tools, and, you've got, all these row houses. Like in my neighborhood, we've got 100 houses. They're all right next to each other, and everyone has their own wheelbarrow and shovel and lawnmower and weed eater. Whereas in many cultures, it's like, well, why would I have a wheelbarrow if you do? Because I can borrow yours and you can borrow my lawnmower. And the idea of self-sufficiency is a very American concept, and not a good way. And I think I think the social media side of things, and even with filters, you put on this filter, you have to display this sense of perfection. And as you seek to only display perfection, yet you know all of your flaws, you only see everyone else's perfection, then you begin to feel like you're worse than everyone else. And it's so easy to look at someone and say, well, they have it all together, and yada, yada, yada. You look deeper in their life and realize, like, oh, wow, they've gone through things and are going through things currently I could never even imagine. And it makes me just think from a healthcare perspective. I wonder if there would be any advantage, or if there would be, if it would be fruitful at all to find ways, like, how can we actually create community and connection? Like, you look at the blue zones across the world where they live longer. Like, what causes people to live longer and healthier? A huge part of that is, sure, it's what they eat and exercise, but also the community, being able to laugh with each other. Like, how many times, like, there's a couple of times a year where I get together with people and I laugh, like, so hard that I'm like, I'm almost crying or like doubled over, like, wow, like that, like, it's super healing. Like, what if you could do that like every week or a couple times a week? Maybe not every day, but, to go years without having that. There's a proverb that says laughter is healing, like medicine to the soul. Right. And so it just makes me wonder, are these things that you guys have thought about, or am I just in left field?
No, I mean, we are created for relationships. Yeah. I mean, that is fact. And I think in today's world, with social media, it's easy. You look at, all you have to do is just drive by a school, a bunch of kids waiting for the school bus, and none of them are talking to each other. They're all on their phones looking down. And so the world has changed. And I happen to believe that's been a real cause of a lot of the challenges that we have, especially coming with our behavior health. I think there's no question.
Yeah, and we definitely took a hit in our adolescent mental health during COVID. That isolation was really detrimental to our youth, and we saw suicide rates, mental health problems skyrocket during that time. Yeah. So it has been a good opportunity for our school-based health care centers to incorporate mental health. So we have students from Pacific University, from George Fox University, who are part of those behavioral health programs, coming and partnering in those clinics and trying to help students navigate this new era of social media and isolation and the expectations that they feel upon themselves, as you said.
Yeah.
And that's another good example of where we're trying to reach out to the community. We did add a school-based health center over at Newberg High School, for the students, so they have a place to go. And it's not just for the students; it's for the parents as well. Parents can go in and get care as well. And I think it gives, it's a way that Providence can reach out to this community rather than just stay within our own walls or at the hospital. I think it's important.
Yeah. Yeah, I think it's not something that can be easily answered in one question when it's a much bigger societal and cultural thing. But it does make me wonder, is there a path forward to, because mental health care is one aspect, there's supply and demand. We have it looks like very much a supply problem with not having enough mental care providers. Yet how much of that is a demand side? Why is there now so much more demand for mental health? What's happening? Can we do anything to kind of deal with the root of the situation rather than the branches, which is maybe much broader than a foundation or a hospital can take care of? These are just the questions I think about and wonder what can be done. What do you?
Well, I think the other area we see it impacting is in caregiver burnout. So we have physicians, nurses with all-time highs in burnout rates, and just this new term, moral distress. And the reason we're seeing more of that is not just, the work is getting harder, patients are getting more complicated, there are demands that society has that we don't always feel we can meet, but also the isolation piece. And we have lost our sense of community with the computer. So people spend half of their day staring at a computer, charting, ticking boxes, doing documentation requirements that takes them away from the personal experience, the connection with their patient, the connection with their colleagues. And so building community is something we're trying to do in the hospital setting as well to address this moral distress that people are feeling, because the work keeps getting harder. And if you don't have people alongside you helping emotionally support you, it's really tough.
Which is actually kind of really interesting tie into the next question or one of the questions I had, which is about how artificial intelligence, which is kind of my hobbies to research, robotics, how that's going to impact healthcare. I don't know if you guys follow artificial intelligence much. So ChatGPT just came out with ChatGPT 4.0, which is like the Omni, which is this new multimodal talking. Have you ever seen the movie Her? It's basically that. So there's on your phone or device, whatever, basically being able to talk in real time to this AI assistant or whatever. So there's a lot of talk about how that's going to affect healthcare. Like you mentioned, being at a computer, doing charting, all these kinds of things. Well, if the bulk of that could be done by these artificially intelligent systems, it makes me wonder, could people go back to the things that they got in for, which is really being able to be that emotional support, having that relationship, and not having to just pass through people transactionally. So is this something you guys have done any research or considered? Yeah,
actually, and Providence is active in the AI venture. A lot of the opportunities we see are kind of, as you suggested, in the efficiency arena. So typical primary care doctor has hundreds of messages in their inbox every day. And it could be a full-time job just trying to sort through those, what's important, what's not important. And so one of the first big ventures Providence has undertaken is an artificial intelligence way to sort those inbox messages. So many of them can go to front desk staff to be addressed. Some can go to the clinic PA. And it can actually identify stroke patterns. So, if someone's reporting, my right face is drooping or I can't move my hand, the AI technology can actually identify that and pop it up to the top of that physician's inbox and say, you need to address this now. Yeah. So those are the kind of things that I'm really excited about it, making the patient care better, making the providers' lives better in being more efficient and able to address this huge workload. I'm waiting for it to come out for email, so it'll sort my emails for me. That'll be the next thing. But what it's not going to replace is the clinical decision making. And one of the downsides of AI is we know that it incorporates old biases into its algorithms. And so, we see throughout history, medical decision making sometimes has bias incorporated into it. And so we would want to be extremely careful that we aren't allowing bias to creep in. And then also that it, if you go in and do an AI search for your symptoms and the diagnosis, there's a lot that can be missed. So it's really looking at predictive models for patients, based on their demographics. Are they someone who we really need to make that extra reach out to make sure they follow up or receive the care that they need, as opposed to someone else who may not need that extra reach out? So some of that predictive opportunity, I think, is where we'd like to see it go.
It really would be a nice tool, especially like Amy said with the caregivers. I mean, to manage an inbox daily, it's a lot of work. Mm-hmm. We talk about caregiver burnout. I mean, that's just one little piece that they can say, hey, you know what, let's take that off your plate. And so you can focus on what's really important, and that is taking care of the patients.
Yeah.
And so there are advantages to that.
One thing you'd mentioned with your interest in cancer, and one of the fascinating things to me is these systems now can look at charts and predict 3 to 5 years out. Is this, based on a CT scan, is this likely going to develop into cancer? Which, to the naked eye, you can't see anything, but yet, there's a much they're very accurate predictions out on what the numbers are. But being able to say like, hey, you have a risk of cancer in 3 or 5 years, and being able to then catch it ahead of time, so you're not maybe having to go through intense rounds of chemotherapy and that kind of thing. So hopefully good things are ahead on that front. I know there's a lot of scary things that could come with that, but hopefully they go away so bad. Another question I had, just as an organization, you've kind of touched on some of these, but what are some challenges that you're facing that you're also working on overcoming?
Well, workplace violence is a big one. We have a lot of frontline caregivers who are sometimes fearful at work. Patients can be either altered in their ability to make good decisions, or just violent in nature and can come in swinging. And we always hate to lose a caregiver to an injury, and then getting them back to work is really difficult. So workplace injury is a big issue. We've implemented a metal detector screening through our ED just to try to address at least the weapons aspect of violence in the healthcare setting. But this is something hospitals across the country, clinics across the country are seeing. So that's a big one, and one that worries me, just with, increasing violence in society. And then retention. We don't have the workforce to fill all the roles. We have a new nurse staffing legislation that's kicking in June 1st. So we are going to nurse staffing ratios, which means that, we will have a certain number of patients per nurse, and that ratio needs to be maintained throughout the day. Well, with that comes a certain number of nurses that we need to hire, and there just are not enough nurses out there to hire. So every hospital in Oregon is faced with the same legislation. So when you add up all of the new nursing positions that are out there, there's no way our workforce is going to be able to fill that role. So training up healthcare providers, nursing, diagnostic imaging technicians, that's another big area of gap. CNAs.
Did you want to talk about the anesthesiologists?
Oh, yeah. So we had a big anesthesia shortage over the past several years. We've had shrinking numbers of anesthesia providers. It's shut down many of our operating rooms. It was in the news last summer or last fall with the Portland service area, big hospitals really having to ratchet back surgeries. And so we've had to contract with new groups that have more creative recruiting strategies. Maybe they're affiliated with a CRNA, a certified RN nurse anesthetist program, that they can kind of feed their groups. But it's been challenging to be able to meet the needs of our community with all of the positions that we need to do that.
Yeah, and not only that, but just, medical borders have been pretty much at an all-time high for a long time now. Yeah. And where do we put patients? This isn't just a Providence problem. This is an industry problem. A lot of hospitals are facing the same issue. You have this log jam of patients. Well, where do we put them? Our emergency rooms are full. And then, where do we send them over to med surg? Do we send them to ICU? Or do we send them to a clinical decision unit? I mean, what do we do? And so that's always a challenge, and just finding the space and to keep up with the demand for healthcare out there.
Yeah. Oregon and Washington have the lowest number of hospital beds per capita in the nation. So we don't have enough hospital beds. And so that overflows into our emergency departments, and then wait time goes up. And
it's no secret, Newberg is a growing community. We're going to need to grow. Our hospital is going to need to grow. We can't stay the same size and keep up with the demand. If people keep moving, and we all know that this is a great community to live in, but we expect that Newberg is going to continue to grow. And so how are we going to keep up?
Yeah. Tough things again. I wish there was one answer that could. That's really it's another example of well-intended, or what's that phrase? The pathway to hell is paved with good intentions.
Good intentions, right?
It's a great idea to say you need more nurses, but then ultimately, if there's just not the workers available, then that means you just have to turn away patients. Is that?
Yeah.
What that means? Yeah.
Or accept a legal violation that we're not meeting the Oregon Health Authority standards for nurse staffing. So that's not an easy decision to make. Either we just leave people in the emergency room because we don't have the nursing staff in our inpatient units, or we take the patients and then we violate the nurse staffing plan, which we don't want to do. So
I feel like there needs to be in tandem with those kind of things, legislation that also provides incentives for, and I know there are some incentives, but more incentives for we need more nurses, so let's, at the same time of making this a legal mandate, let's also do something that's going to give that supply for maybe people going into college saying, hey, better loan forgiveness or, other things.
There was some legislation last year that community colleges could start offering bachelors in nursing. I think I'm getting that correct. But trying to expand that workforce by increasing training programs. We need to train more of these.
It's not just hospitals or clinics; it's skilled nursing facilities. They're in the same predicament. Where do you get the staffing? Yeah, it's shortages everywhere.
Yeah. Well, I appreciate you guys sharing all this. A couple more questions. One more is just as the community getting involved. So I guess the foundation would be one.
Absolutely.
And if they want to get involved with the hospital, besides getting an injury or sickness, how could they get involved?
Yeah. Well, I would say as far as the foundation, I'm like I said earlier in this talk, the foundation statewide, our mission is that we inspire generosity by connecting people to Providence, and there's that word connecting. We're all about relationships and connecting people. And that's through research, patient care, and wellness. And in Newberg, we've added an additional line to that, and that is keeping exceptional care close to home. We want our citizens in our community to not have to go into Portland if they don't have to. Come to Newberg, come to Providence Newberg, receive your care, your treatment, and go home. That's our ultimate goal. And in order for us to do that, we need to make sure that we have the best equipment. We need to have the best physicians and nurses, the best caregivers. We need to be able to offer the best services for our patients. We need to make sure that our facilities are up to par and are in good conditions. And for us to do that, we need people to support us financially. Yeah. And, I think about, I mentioned earlier about equipment being one, if we want to be able to have the best equipment. So, and our caregivers, we need to retain good talent. Like Amy was saying earlier, it's so important that we can recruit good talent. We all know that Newberg's a great community to live. That's no secret to us here. But we do have to do things that can kind of retain good talent. One of the things that the foundation has is we have a program called the Mike Oberding Education Fund, where we can help our caregivers, for those who are needing continuing credits. We would like to pay for that and fund that. And it's just a nice retaining tool for us, so we can bring in the good talent and they would choose to stay here. Also, as far as some of the equipment, some of the examples of some of the equipment that we've been able to bring in recently is, we've brought in, audiology devices for our rehab services and for our birth center. Bilirubin meters for our birth center. It's a device that measures jaundice in infants. We recently purchased a pulmonary function machine. Back in 2021, our foundation purchased 8 new panda warmers for the birth center, and the panda warmers are the little mini beds that the little infants lay in. They measure, body temperature, weight, breathing capacity, all those things, and they've been a true blessing. I know for our patients that come to our birth center. In 2022, we bought new ergonomic functional beds for our emergency department, which was a great thing that we raised at our signature fundraising event, Hearts of Gold, back in 2022. And so those are some good examples. Another good example is that back in late 2022, Dr. Janelle Utsi, who's one of our lead breast surgeons with the Cancer Center, came to the foundation and said, "Hey, we need a device called a Savvy Scout." And a Savvy Scout whenever a patient goes in for breast cancer surgery, they have to be wired. It's a very uncomfortable process. It takes 45 minutes to an hour. What the Savvy Scout does is it's a wireless system, and it identifies the tumors through wire. It doesn't require to be wired up. It's more accurate. And adding the Savvy Scout to our cancer center, if you're a breast cancer patient, you can receive pretty much the same quality care as you have if you went to St. Vincent. And that's something we're very proud of. We want, like I said earlier, we want our patients to be able to come here, receive care, and go home. And so that's just another thing that the foundation can provide. In August every year, we hold our signature fundraising event, Hearts of Gold. This year, it'll be our 24th year. Our beneficiary this year will be our cancer center. We're going to be raising funds for cancer patient care. And so we're really excited about that. And that's going to be Thursday, August 15th. And it'll be held at the Chehalis Cultural Center. And it's going to be a great evening.
Okay.
Yeah.
What from your perspective?
There's a lot of things that we partner with the community in. So when you support other community groups, you're supporting our mission as well. I mentioned some of those community partners. So helping meet the social needs of our community helps us do our job. And then the foundation is a great avenue. If someone wants to get involved with Providence specifically, they have different funding buckets that you can even kind of designate. I want my funds to go to the community garden so our employees can grow food for the fish bank. Yeah. Or I want my funds to go towards, children with developmental needs or, other buckets. So or they just have an area of greatest need fund. So, that's really the best way to someone to get financially involved. And then, I would say just being good partners in the community and helping meet our social needs in the area is a great partnership that we appreciate.
I do want to add as well that we do have a very wonderful, robust program, the Providence Newberg Children's Development Institute. They're housed over on Villa Road, over across the street from George Fox, and they focus on 3 areas: occupational, physical, and speech therapies for children with special needs. We talked earlier about some of the challenges. Some of the challenges that we have is that they need a bigger space. We have a waiting list for families that are coming to them saying, "Hey,
we're on it.
We need help." Yes, we need help. But one of the challenges is that if we don't have the space, if we don't have the caregivers who can fill that space, we're kind of limited on what we can do. And here we are at a place where families really need that additional support, and we do such great work, but it's just hard to serve everybody when we just can't have the folks to do it.
Yeah. Well, that brings me to my last question, what I like to ask everyone on the podcast. We did talk about a lot of challenging things, but what gives you hope for the future of Newberg?
I have hope when I think about the people that we work with, the people that we serve, the amount of talent and devotion in this community. There's not a lot of places where a hospital can be such close partners with the community and really feel like we're part of the same team. I think that's unique to Newberg. So it's really serving the people and knowing that regardless of what legislation, what, factors outside of our control happen, that we still have great people here and we're going to weather it.
I'm really impressed with this community's ability to collaborate. We've got such good partners throughout, whether it's the faith-based community, whether it's, obviously we have George Fox, we have ADEC, Providence. Love Inc. is doing an amazing work around our community. We got a very service-oriented community, and we've got 3 Rotary clubs in this community, and that's all service above self that want to do nothing but make the community better. And so I'm just really impressed with the way that this community, people love this community, and people are willing to work together. And I see some good things for Newberg.
Absolutely. Well, thank you both so much. It's been great getting to learn more about the Providence Foundation, the hospital, the role it has in Newberg. And I know there are challenging times we're in right now, but I do believe great days are ahead as well. So thank you both so much.
Thank you, Daniel.
Thank you, Daniel.
Thank you for tuning in to the Giving Town podcast. If you enjoyed this episode, please consider sharing it with a friend who you think might benefit from hearing it. While more and more people are continuing to hear about this podcast, I still need your help to spread the message about all the people and organizations that make Newberg so great. Well, thanks for tuning in, and I'll catch you in the next episode.